And before we get started, let me share with you a few details about the session we'll be seeing today. So this is the 8th session of the virtual educational channel, and we had the chance of being hosted by the University of Stanford today. So today we have 75 participants registered coming from 26 countries, which is quite a lot. And I will let Robert start the introduction right now. Robert.
Okay, thank you, Frederick. I will be brief. I wanted to say that, as you can see, it is still there, the COVID pandemic, with all the constraints that are imposed on each of us in our daily lives. And the session that follows is a new step in the response chosen by OESO to address a situation that has never been encountered by any of us. So today, indeed, is the 8th of the clinical case discussions organized by OESO-SEMPIRE to remain true to our mission of education in all the different fields of multidisciplinary esophagology. On this vast platform, which originated one day not so long ago in Palo Alto. I'm sure that George and John have this very close in their memories. The 15 pilot centers of excellence in esophagology come in turn to propose to the scientific community a case, that of a patient chosen by the pilot center team for the particular educational aspects posed by the diagnosis of the possibilities of treatment. This is the particularity of the great OESO-SEMPIRE platform, 15 pilot centers spread over the 5 parts of the world, each one with recognized competences in multiple specialties of gastroenterology, and which are committed to a program with one goal: advancement of the science of esophagology. Si tu veux montrer la slide, Frédéric, merci. The science of esophagology. And now, after a highly appreciated first performance nearly a year ago, it is the name of Stanford medicine that comes back to you to share once again a diagnostic and therapeutic journey that you will find challenging in its complexity. Indeed, listen, obesity, the prospect of a transplant, an EGJ outflow obstruction, and an indication for bariatric surgery. Complex, isn't it? And to answer this question, a very distinguished team was assembled at Stanford. John Clark, internationally recognized gastroenterologist and now a president-elect of the OESO organization. George Triadafilopoulos, gastroenterologist and endoscopist, president of the advisory board of the platform, and one of the originators and the pillar of the platform. And Dan Azaguri, a fine representative of surgery and director of the fellowship program at Stanford. Last but not least, Dr. Professor Patricia Garcia, assistant professor in gastroenterology and hepatology at Stanford, will present the case. In addition, a whole panel of experts has been assembled to lead a discussion that promises to be once again lively and instructive. You'll see.
Okay, let me just share my screen.
Okay, well, thank you very much. Thank you very much, both Frederick, as well as Robert. We greatly appreciate the introduction. We are delighted to be here and very psyched to do a case again here and to be linked with ESO in terms of doing this. Next slide, please. And I'll jump ahead towards the next slide, actually. So I'd like just to say a few words about the group at Stanford. We have the Stanford multi-dimensional program for innovation and research excellence in the esophagus, which is termed SEMPIRE. And this was really the vision of George Triadopoulos, who came up with the idea. Next slide, please. Of trying to take patients coming in with esophageal symptoms and then try and link them with clinical, structural, and functional assessment to get a sense of exactly the mechanisms at play, and then try to align that with the most optimal therapy in terms of medications, endoscopy, as well as procedures. Next slide, please. As part of SEMPIRE, we have 3 pillars of excellence, and we've tried to focus on research as well as innovation, clinical practice, as well as teaching. And we've broken those down within different categories. And so in clinical practice, we see not only primary esophageal patients, but also secondary referrals who are seen as well outside. And from the standpoint of education, we focused on both teaching local doctors as well as the public. Next slide, please. And what we've really tried to do is to take that situation where one patient comes in and they see an expert and then get referred from one expert towards another, and to try and link everything in one house and one platform. Next slide, please. And so as part of the SEMPIRE, we've tried to interface at different steps along the way with referring doctors, with both a GI as well as subspecialty and PCPs. We've tried to have more of an outreach both locally as well as internationally, to tie in basic as well as clinical and translational research with what we're doing clinically, interface with different specialists such as pulmonary and ENT and oncology, and then link in imaging and pathology. Next slide, please. As well as to incorporate newer technologies within the diagnosis of these disorders. Next slide, please. And we're very, very privileged and honored to be working with ESO on this platform. This has for us been a great way to take what we're doing on a much smaller scale in Palo Alto, and then expand this towards an international reach. Next slide, please. The Stanford GI and Hepatology motto is to study critically, practice well through mentorship, opportunity, exposure, resources, touch locally, reach globally. And we think that working with ESO gives us a chance to make that happen. Next slide, please. For this particular case, we have a very distinguished expert panel that we are delighted to have on board. I've put down the names here, but you can see a very nice mixture of both gastro as well as surgery. We have representatives here from 5 different countries, including 2 from Boston, 2 from France, 1 from Canada, 1 from Australia, as well as 1 from Austria. These people are all leaders within the field and top experts, and we are delighted to have them on board. So without further ado, I'm going to pass the reins towards Patty Garcia. This is Patty's first foray into ESO, but she is a star in our group who is clinically fantastic, very articulate, and has done a really masterful job setting this case up. So once again, thank you for the chance to have our group present this case, and Patty, the floor is yours.
Thanks, John. Nice to virtually meet everybody. And I'm actually going to pass the ball quite quickly to Dan, who's going to start off introducing our case, and then I'll pick up the ball from him as we talk about the journey that this patient took through our diagnostic motility lab.
Thanks, Patty, and thank you all for the opportunity to join the group in presenting today. And as we did clinically, I'm going to do just introduce the case, and then most of the evaluation and management of the case thereafter is going to be taken over by Patty, just like we did when I first sent this patient to her. This is a 57-year-old gentleman with a BMI of 44 and end-stage kidney disease due to his insulin-dependent diabetes. And he's on dialysis and can't be listed for a kidney transplant because of his BMI. And he was therefore referred to us for evaluation for bariatric surgery. And talking to him, he doesn't have significant upper GI symptoms, no dysphagia, no significant GERD, which is the one thing that we dig into a little bit when we see patients before sleeve. And we started him on a kind of standard process to work him up for a sleeve gastrectomy. In order to do that, we usually order a upper GI to assess for essentially any hiatal hernia. And the upper GI came back as distension of the esophagus with a tapered narrowing at the GEJ, concerning for achalasia. Again, the patient has no symptoms that he complains about. Asking him and probing him again, he doesn't really have significant dysphagia at all. Do you want to go to the next slide? So we discussed this a little bit further with him and about the different options. As most of you know, these patients won't get listed for a transplant unless their BMI is below 33 or 35. And we often perform bariatric surgery on these patients as a bridge to get them to a transplant. The problem is that we typically avoid doing Roux-en-Y gastric bypass in this situation for a series of reasons. But importantly, in the kidney transplant population, there have been reports of increased acute kidney graft rejection after gastric bypasses. There's a significant rate of hyperoxaluria that has led to early graft loss, and that is a particular concern to our transplant colleagues, and we've obviously discussed this with them, and therefore we try to avoid performing a gastric bypass in this patient population. So as we're starting to look into his upper GI motility and his symptoms, this is something that we had in mind when we referred him to Dr. Garcia to help us evaluate his upper GI. Patty, you want to take it from here?
Yeah. Okay, so I'm going to ask for a discussion in a minute about what the next step is, given what we know about this patient. And here are some options that I want you guys to start thinking about. But before I get full discussion, I want to take a little detour into esophageal radiology. So here are the options to think about, and then we'll come back. I'd like to detour into esophageal radiology because, as you know, there are a lot of studies that we do to look at the esophagus. There's upper GI series, there's esophograms with tablets, there's time-varying esophograms, there's modified barium swallows. And usually we end up with one or more of these when we see patients, either preoperatively in this case, or for some upper GI clinic that we're seeing them in clinic. So in this case, the patient had an upper GI series that was concerning for achalasia. So I thought we could spend a few minutes talking about the sensitivity and specificity of these kinds of tests for achalasia. So what I put here is just a very kind of high level overview of some of the protocol differences amongst the tests. So upper GI series are really to look at the whole upper GI tract. They're not protocolized for the esophagus. Now, of course, they take images of the esophagus, but they're not as many or as detailed as a dedicated esophagram, for example. Now, that tends to be more of an issue of sensitivity, where they may miss a finding in the esophagus as opposed to specificity. And in this case, they actually found something. So kind of hard to say, what that means. Then there are timed barium esophagograms, and those involve radiographs taken at 0, 1, 2, and 5 minutes after ingesting usually 200 cc's of barium. And you look at the height of the barium column at 1 minute and 5 minutes to see if there's evidence of outflow obstruction. Now, if there is no barium column, the barium just flows right through, they go right to a standard esophagram. Addition of a tablet to esophagram, so it's usually a 13 mm tablet, that helps us detect more subtle obstructions that you might miss with just liquid barium. And then you have the modified barium swallows, which are protocolized to take a lot of detailed images of the upper esophagus and the pharynx, looking at the oropharyngeal phase of swallow. And usually it's done with speech therapy, where in addition to liquids, they're doing applesauce and crackers and other things, really, again, looking at that oropharyngeal phase. Now, when you think about the sensitivity specificity in regards to achalasia, there are a few studies that have compared barium to manometry, using manometry as the gold standard. And I'll say anecdotally, the fact that barium isn't 100% sensitive seems intuitive, because we think of manometry as being the gold standard, at least in this era. And you can see here a table. There was a paper that was done by Yamasaki and colleagues, and they looked at 46 cases of achalasia using manometry as the gold standard, and there were 10 that were missed by esophagram. And you can see here that the esophagams were either normal or they showed a corkscrew pattern. But more relevant to this case is the specificity. And I often think of esophagams as being pretty specific when they say that there's tapered narrowing. But what you'll see here is that, at least in some of these papers, the specificity, while good in the high 80s, isn't 100%. So there still can be some false positives. So I'll go back to the previous slide and ask for maybe a couple of thoughts about what people think should happen next to this patient.
Patty, this is George. I was wondering, given the fact that the patient does not have symptoms, do you think that an X-ray examination would be valuable, or is it something that we need to do more specific barium studies, or just a simple esophagography would be enough?
I mean, I think that's the question. I mean, the last option here says maybe you don't do anything, right? Maybe this is just a bit of a incidentaloma, right? The upper GI series wasn't done to look for achalasia or because the patient was having dysphagia. And we do CT scans all the time where we find little blips and we think, okay, that's not what we were looking for. So I think that's one argument to be made, that, maybe this is nothing. You continue with preoperative planning.
Yeah, well, I'd probably make the case, this is John, that if you're doing the study as part of a pre-op and you do find something that stands out as abnormal, then I think there's at that point an obligation to pursue it further. Now, you can question the clinical relevance of it if they don't have symptoms with it, but if you've done the study per a pre-op design, then I think if you do find something, you are warranted to then go past that. I personally, if I saw this with a barium study, I probably wouldn't do another type of barium study. I'd probably follow it with something else. And I think manometry is probably the next one that I'd do. But that being said, I'm curious what the expert panel thinks here, and if any of you would like to comment on this.
I agree with doing manometry, actually. Of course, I'm a little bit biased because that's where I usually turn in these kind of situations. But and we haven't actually seen the images. I think that to some extent, seeing is believing. We see sometimes overcalls on radiologic studies, or many times we see things on radiologic studies that we as surgeons, and I'm sure gastroenterologists as well, just sort of kind of ignore and say, well, that's not really the appropriate test to make this kind of diagnosis. It might help, but really we would need something more concrete. The lack of symptoms definitely makes one think, well, what are you really going to find out? But I mean, we do, for example, at least I certainly do, a manometry on every patient I'm going to do an anti-reflux procedure for, regardless of what other studies may have shown, because there are findings that we reveal on manometry that may warrant further workup or consideration of an alternate procedure. And I know there's some debate on that, but that's still largely the general practice and what has been recommended by guidelines. So I think manometry is the appropriate next step, although I would like to actually look at the films myself to see what they're really indicating. Are we talking about a tapered narrowing? They say is suspicious for achalasia. Well, that has a certain look to us, to all of us who see those films on the GI and surgery side. And I'd want to take a look at that myself and say, okay, yeah, that could be something.
I would say that, I agree. I think we should definitely evaluate it more, especially since it might have implication on what type of surgery to do next. But I think that, in addition to manometry, probably endoscopy is important too. I know the description, the tapering would suggest something like achalasia, but we still want to make sure that there's nothing, mechanical that could, they're subtle, that could, provide you with that appearance. And we're thinking about proceeding with surgery next. I think that definitely also needs to be rolled out. So I think the best would be doing endoscopy maybe with an endoflip at the same time as well.
This is Lee. I see everybody. I agree with Walter. I think I would do an endoscopy first. You don't know that it's not infiltrating cancer, peptic stricture, something like that. That obviously going to need motility at some time, but I'm going to rule those really bad things out pretty quickly, and it's a pretty simple thing to do.
This is Hiroshi, if I may. Yes, I'm agreeing that the first thing, and I thought Dan actually mentioned that an endoscopy was done. I can't recall, but one plea that I do make, though, in an endoscopy is the quality of the retroflex endoscopy. That is, you're in a really privileged situation with endoscopy to be able to continue to inflate, unlike say in the esophagus, which the patient quickly belches out. But you can, in a retroflex position, really inflate to induce both sliding as well as easily missed paraesophageal hernias. So really a quality endoscopy with patience, sufficient insufflation of the retroflex vision particularly is warranted. This is Hiroshi.
And always a biopsy. Don't forget the biopsy.
John, I agree with you that if you're going to do a test, if you find something, that should be followed up. The other comment I would make is that, unfortunately, radiology expertise in doing and reading fluoroscopic barium studies is declining. So you really want to look at those images yourself and decide if you think as well that there is some distension, maybe tapering. But definitely endoscopy to rule out a mechanical obstruction, and then whether flip or manometry, whatever is available.
Okay, sounds good. Well, thank you guys for the discussion.
If I could just interrupt as well, it's Matthew Reed from Australia. I was under the impression that Dan had mentioned that they had the endoscopy already, but as the primary operator doing the bariatric surgery, I always like to do it myself. So I don't know whether you had the scope done in your own institution, but that would be something I would consider as well, repeating the scope just to see for myself what's going on.
Gotcha. Well, thank you again for the input. Actually, this patient hadn't had an endoscopy here or anywhere. And I think Dan ended up doing what we all sort of agreed on here, which is to refer him for an endoscopy and an esophageal manometry. And so I actually met him in endoscopy. So I hadn't seen him in clinic, but it was sort of a direct referral. And I ended up doing his endoscopy. And I'm not going to show any images here, except to say that I think it was a quality endoscopy, and I did fully insufflate, and it was very normal. There was maybe a little bit of erythema in the stomach and in the duodenum, which I think is often seen. I biopsied everything, proximal, mid, distal esophagus, stomach, duodenum, and all the biopsies were normal. But what I want to show now, or kind of get into a bit more, is the manometry. And so before we review the specific manometry, I want to take a little detour into how we interpret esophageal manometries in general. And I apologize for those of you on the call for whom this is review, but I just want to make sure we're all on the same page. So the Chicago classification is the most widely accepted and utilized algorithm to interpret esophageal manometry. And it was first conceptualized back in 2007, although its first official iteration and publication was in 2009. And at that time, there were 4 authors, and it was just a new publication with the goal to develop a standard set of measurements and metrics and terms to describe manometric findings that would allow esophagologists throughout the world to speak the same language, so that when we were communicating about cases, we were using the same terms and agreeing and having consensus about how we interpret these studies. Now, the most recent iteration, which is version 4, was published actually just 2 months ago in January. And this version had 52 authors from 20 different countries. And of course, there have been some iterations between the first one in 2009 and this one, but the goal of this update was to get a larger, diverse group of experts from throughout the world, and to dig a bit deeper on manometry protocols, and also redefine the definition of EGJ outflow obstruction, amongst other things. I'll spend just a minute touching on the manometry protocol. So essentially, from the very beginning, the foundation of manometry protocols has been 10 supine swallows. And the consensus guidelines have always focused on analyzing these 10 swallows using specific metrics. That said, over the last several years, there's been a focus at looking at parameters in different positions or after other provocative maneuvers or challenges to help us really better understand physiology beyond that foundational 10 supine swallows. So the latest version of the Chicago classification recommends that in addition to that foundational 10 supine swallows, there should be multiple rapid swallows, which is a method that allows us to assess peristaltic reserve, which I'll talk about a bit later. Also, there should be 5 upright swallows to validate mostly EGJ metrics that we may see in the supine position, and to do a rapid drink challenge, which also helps to clarify outlet physiology. They also mention that on a case-by-case basis, you could consider other provocative maneuvers like solid test swallows or extended observation periods for rumination, or even pharmacologic provocations based on the case. Now at Stanford, our protocol has included multiple rapid swallows and upright swallows for some time, and we agree that this new version of Chicago 4 is a good idea because we do think that these extra maneuvers shed light on esophageal function. And before I show you the actual study, I want to highlight one more thing, which is a metric called the integrated relaxation pressure. And that assesses the pressure of the esophagogastric junction after a swallow is initiated. So again, I'm sure that this is familiar to most of us, but after swallow, there's a period of deglutative inhibition during which the EGJ should relax to allow bolus flow from the esophagus into the stomach. And so the IRP looks at the esophagogastric junction for the 10 seconds following initiation of swallow and identifies the 4 seconds in that 10-second window that have the lowest pressure. So normal in the supine position is less than 15 millimeters of mercury. So the GEJ should have less than that degree of pressure for normal bolus flow. Normal in the upright position is less than 12. And that line of 12 millimeters is new from Chicago 4. Of note, we talk about the EGJ and not the LES because this integrated relaxation pressure, this 10-second window, indexes pressure not just from the LES, but from the crural diaphragm, from mechanical obstructions, like from a fundoplication, and from other things, even vascular artifacts. So we talk about EGJ pressure and not just LES pressure. So here's this patient's manometry. So in the upper left, or maybe in the upper right, it's the composite image of the 10 supine swallows. So basically taking all 10 of the supine swallows and making a merged image. And you can see here, I'm not sure if you can see my pointer, but you can see that at the EGJ, there's ongoing pressurization and that there's bolus pressurization above the EGJ. So between the contractile front and the EGJ, there's a bit of pressure there, which we think about as being reflective of outlet obstruction. So the IRP for the supine swallows was 20. And again, we think normal is 15 or less. On the bottom right, you can see an upright swallow. And you can see again that there's ongoing outflow obstruction and that there still is that bolus pressurization between the contractile front and the EGJ, again, sort of making you think that that outflow obstruction is real. You can see here too, though, that there does seem to be some contribution from the diaphragmatic contractions. So you can see each of these little red blips is the diaphragm contracting, and that's going to inflate the IRP. So maybe there's a little bit of that going on here as well. But the IRP in the upright position was 16.7. And then the last thing I've included here is the multiple rapid swallows, which is the image on the bottom left. And so what you can see here is that after repetitive and rapid swallows, there should be inhibition of the esophageal body and the sphincter, after which there should be a high amplitude contraction. And the main point of this multiple rapid swallow maneuver is to look for that post-swallow high amplitude contraction. And we use that as an index of peristaltic reserve. So in most cases, when we're really looking at this, is a patient who perhaps has evidence of weak peristalsis. And if you see an appropriate augmentation after multiple rapid swallows, you think that maybe there is more reserve than what you're really seeing in the supine swallows, for example. In this case, while you see a fairly reasonable augmentation, one of the things I think is notable is that you don't see a good inhibition of the esophageal body or really good relaxation of the LES. Now, these aren't kind of official Chicago metrics, but again, I think when we do these extended maneuvers, they help us answer questions that we may have in our mind, especially about EGJ outflow. So in this case, if I see that the outflow still seems to be obstructed or that there isn't complete inhibition in the body, that makes me think that yes, maybe there is something real going on here. So with that, I'll stop and ask for some further discussion. So given what we just talked about and given the patient's manometry and the previous findings, what do you think we should do next? I'll say that after we have this discussion, I'll talk a little bit more about the new Chicago classification thoughts about EGJ outflow, but I just wanted to get people's sense here about what they would do now.
Patty, this is excellent review of the Chicago 4, and I was wondering, for what Dan is planning on doing, should we consider that because we found an abnormality? Is this important to Dan, or this is of academic interest?
Well, maybe I'll ask Dan.
So, you'll see that's probably the theme of this. There's part of this is how much are we chasing something down a rabbit hole in a patient who's asymptomatic, and where we wouldn't have done his upper GI in the first place. He would probably have a sleeve by now, and I won't get to the end of the presentation. The flip side of this coin is to say, contrarily to when we're trying to diagnose a patient for the sake of diagnosing their symptoms, here it's a pre-op evaluation where we know that we are going to potentially uncover or disrupt things in a way that will lead to potential symptoms, right? And I think we'll see how far we go and how much time we have for discussion. But the problem is we don't have a great understanding of what happens in terms of post sleeve. I won't go into. I don't want us to go into the end of the discussion, but we don't know what happens in terms of consequences from the sleeve, in terms of esophageal motility and acid reflux and all these other things. And because we might uncover something and now have a patient who's potentially very symptomatic after the surgery, I think it's worth going down this rabbit hole in this specific situation to make a decision about what the ideal therapy is going to be. And it's a little bit different than when we're trying to evaluate a patient that comes in with a symptom and a complaint.
Okay, so maybe I'll look to other. Yeah, great.
Dan, do you think in this situation, when I think of sleeve gastrectomy, the big worry that I always think about afterwards is GERD. But here we've got almost the opposite with the outflow obstruction. Do you think that this is still as relevant clinically as if we were more looking at a GERD diathesis instead of an obstructive process?
Yeah, and typically, I agree. So typically what I screen for, at least in terms of symptoms, is pre-op GERD, not pre-op dysphagia. And, you know, I would love to see what, you know, Roger and Lee and Denis and others think about this. But I do think until we have a really good understanding of what happens in terms of motility and pressures after a sleeve, you are now, you know, if they have some form of achalasia and some form of EGJ outflow obstruction, I think increasing the pressure underneath with a sleeve is likely to, again, potentially uncover some subclinical symptoms that they have, and you're again opening the door to creating symptoms in a patient who didn't have any before. So that's what we're thinking about now. Whereas, you know, if we were to do a gastric bypass, yeah, I would not worry about it at all.
So I think, you know, first and full disclosure here, I don't do bariatric surgery, so I'm not speaking from perhaps as high a level of knowledge as some of the other folks on this group. But right now, again, if you have a patient that you're working up for a reflux issue and you have this finding, and in alignment with the new, you know, Chicago classification, dysphagia or some obstructive symptom is a necessary component to conclude an actual diagnosis of EGJ outflow obstruction. And so, you know, D might be the right choice. In hindsight, of course, I'm pretty sure D is not going to be the right choice here, that we do nothing further. You know, so that's obviously the wrong answer. But but I think according to, you know, what our understanding is, apart from this case, kind of in an all-comer situation, you know, we probably wouldn't do anything further at this point. But I think Dan's point about the fact that there are still some unknowns, particularly with respect to motility post-sleeve, that, you know, we found an abnormality. Now that abnormality that was seen on the upper GI has been corroborated by an abnormality we see on esophageal manometry. So even in the absence of symptoms, going into an operation like this, it makes sense to do something else to really try to tease that out, because as we all know in both surgery and gastroenterology, once you've done something on these patients, they can have symptoms that can be very hard to explain and even harder to deal with. So I think it's worth essentially working that up to the hilt. Based on my own personal experience and what, you know, I have used more recently, I actually am still not somebody who really regularly uses EndoFlip. I have a feeling that the majority of the folks here are going to say, okay, let's do EndoFlip. And that makes sense. I think in this situation, that probably makes a lot of sense. I think a timed barium swallow could be helpful, but the EndoFlip is going to provide a little bit more specific information. So I think that's probably the answer that we're going to agree to as a group.
One question I have, looking at the few pictures that were shown by Patty, I don't know if I missed mentioning of it. Was there signs of a hiatal hernia? Because I think in a couple of the images from the manometry that were shown, that looked like there could be possibly you know, maybe a hernia. And if that's the case, I think And I don't know what the baseline tracing part showed. And I think if that's the case, I think endoflip is sometimes a little bit harder to interpret when people with the hernia or significant hernia. Then maybe a time-bearing swallow would be more useful in that case to see if there's actually clinically significant outflow obstruction.
Yes, Patricia, let me just opine if I may. This is Hiroshi from Boston also. So what often happens in these kind of readings is really the importance of where the landmarks are. And the first thing to note here, as was already mentioned, is the enhanced diaphragmatic impressions that you're seeing with breathing. But then you have to ask yourself, where is the respiratory inversion point? The respiratory inversion point is actually far too early. It is not where you're putting the diaphragmatic impressions. So as Walter is saying, there often is a mistake not appreciating that where you are putting the LES, and these numbers get very skewed because even at baseline, you're starting to count the diaphragmatic impressions as part of your baseline. But what you had noted is that the baseline between those breaths did not really decrease during, if you ignore the breathing, or in this particular case, inspirations particularly. The area that you're putting the LES, I suspect, is where the red dots are, right? And that—
a little bit higher.
Oh, you are putting it higher. Good, yeah. Then you're already making the point that Walter's making, that instead of calling this the GEJ obstruction, if it is higher, meaning not where the red dots are, but where the end of the respiratory, contraction is. And I had already assumed that you were putting it where the red dots were, okay? But if it is higher, then you have another issue because it doesn't relax, right? And then the other issue that we found, of course, from our nitric oxide knockout models, which is the achalation model, is that, and this is why Walter knows, I always insist on that raw tracing, right? Is there a rebound contraction? Okay, other than the loss of LES relaxation, which is the case here, the loss of rebound contraction is also another feature. So you can see here, as Walter is saying, that there may be an underappreciated anatomic problem here already, that the LES relaxation is not truly there, I would say, and that the common problem with working on the computer spit outs is first the importance of appreciating where that respiratory inversion point was, which is far higher, as you see, the distinction between where the true LES is, which you really can't see here, okay, not much, versus is this really where the diaphragm is? So I'm just throwing it out there because there are other reasons why you could look at this, but as Walter is saying, is there an anatomic problem? I would raise that very early.
And is there any way that you can use your mouse to show these points to the general audience?
Can you guys see my mouse? No.
No.
There is a way. Let me figure out, I'm gonna Google the way. I know there's a shortcut key that lets you put the mouse on. But maybe while I do that, one thing that I'll kind of throw out there too is that for those of us who read manometries, when you put the brackets to calculate that relaxation pressure, it's what I was saying before, you bracket the whole EGJ, which includes the LES and the crural diaphragm. So even in patients who have large hernias where there's a separation, a much clearer separation than you see here between the LES and the crural diaphragm, in theory, those brackets where we calculate that pressure encapsulate both points. And so when you get an IRP, it's going to give you the pressure associated with that hernia, not just the LES pressure. Now, some of us will sometimes take the brackets and just put it around the LES so we can really just get LES relaxation pressure. But those metrics, this software is not meant to calculate that. And so it's a little bit futzing to kind of do that. And I think that's one of the issues maybe with the software, maybe that kind of needs to be in further iterations, is how can we truly separate out just LES pressure from crural pressure, and maybe that's something that manometry is not particularly good at doing. It's certainly not particularly good at doing now.
Patty,
You make
a rapid drink challenge by any chance?
We didn't. We didn't. It wasn't part of our protocol. This was pre-Chicago 4, and it's not part of our protocol yet.
Because you get a bigger challenge and more prolonged stimulation to get the LES to relax with that. And the second question I had is whether you have impedance with the manometry. Was there any bolus retention? Because we talked, I mean, Chicago 4 really clarifies the fact that if you have a manometric EGJ outflow obstruction, is it functionally doing anything? So this is where you want to know with the timed esophagram or with impedance with the manometry, is there actual outflow obstruction or is it just a number?
Yeah. So hopefully you guys can see this pointer now. So there was impedance for the manometry. I'm not showing it here. There was bolus retention. I'll say that one of the ways that we look, though, also for evidence of bolus retention is this kind of bolus pressurization. So in theory, I'm going to kind of highlight here, but there's this kind of angle here between this is the contractile front and this is the kind of composite EGJ. And so there's this kind of little wedge space here between the contractile front and the EGJ where you can see if there's pressurization. Now, in theory, to be qualified as pressurization, that needs to be 20 millimeters of mercury or higher. And in this case, it was. And you can see here that even on the upright swallows, there's this kind of hazy green pressurization showing you that there is some pressure between the contractile front and the EGJ. But again, you know, is that in part related to this diaphragmatic contraction? So these kind of red blips, you see sort of this negative intrathoracic pressure, and then that's kind of capitalized here by the diaphragmatic contraction. So this is the patient breathing. You see that there is a bit of a prominent diaphragmatic component. So maybe there's pressurization because of that. You know, it's hard to separate out also whether there could be a small hernia. So as we've all seen on manometries, you know, there can be these sliding hernias. So if you look here, maybe, if you look here on the multiple rapid swallows, what you can see here is that the contractile front sort of ends around here, and that's probably where the true LES is. And here there's a more pronounced separation between the diaphragmatic contraction and the LES contraction. And so I think he probably does have a sliding hernia. You can see here too, again, it looks like it probably ends around here, and here's the diaphragm. Now in the composite image, that's going to get lost, and this is also probably reflective of the truth, which is that it's a sliding hernia that's sometimes more pronounced than others. But I do think that this patient has a bit of a hernia.
Patricia, that is the point that I was making, is that where you put those double bars for the LES, in this particular case, and I don't like the composite here because it already makes it a composite, but let's say there's a true outlet obstruction, and in your impedance, you already have a bolus that's mounting up to create that front. Then what you should see is a pressure equalization in that bolus. In other words, you and I are in the same room, we feel the same pressure. So when you look at the actual tracing waves, you'll find out that in an actual obstruction in the presence of an impedance showing you that common cavity, those waves will look identical. I suspect that that's not the case here. And as you were just pointing out, in the particular case of the, let's say the left panel there, where you see the respiratory inversion point, during that time that you're having an obstruction or obstruction, you're seeing actual warm spot in between what you just suspected might be the LES and the diaphragm, right? So that means that during this time, and often in the presence of a longitudinal muscle contraction, we often put the diaphragm too low. I mean, we put the LES too high. Does that make sense?
Mm-hmm.
And in this particular case, you're missing a rebound contraction, which is yet another hallmark of a loss of nitrogen innervation.
And can I just kind of point one thing out? You know, looking at that, and if indeed the true LES is that high, I find it hard to believe we wouldn't see evidence of that on either endoscopy or upper GI X-ray. I mean, I have to say, and I'm sure the other surgeons on the call will say this too, like when you have a separation like that, one or the other of those two studies, if not both, will usually show you pretty readily you know, a hiatal hernia. And we know those, you know, all three investigations do complement one another in that way. And there's
respectfully, Roger, you know, doing this for a while, I have to say that when you are doing it, you're probably doing it with sufficient insufflation. The barium swallow or anything else does not inflate the stomach enough, even if you were to do fancy maneuvers to create the equivalent pressure in the stomach to blow out that hiatal hernia. I do a lot of Barrett's work where we realize the measurements of the LES and where it is, or the GEJ junction, is all over the place once you find out that you can blow them out. And that's a physiological reason. And during a swallow, because often as you start losing nitrogen innervation, you get enhanced longitudinal muscle contraction, which you don't appreciate on manometry. Then you get this kind of heaving up of the actual LES into the chest. And that's what we're seeing here.
But don't you see that on endoscopy though, when you're distending the stomach and retroflexing?
Correct. And many people don't do that. Many people just retroflex without enough insufflation. So often a paraesophageal or a sliding hiatal hernia is underestimated.
Yeah, I mean, I agree with the underestimated part, you know, and those measurements are really, you know, really fuzzy, I would say. You know, they're fuzzy endoscopically and they're fuzzy radiologically. You know, obviously it looks different in surgery, and the physiology during all three of those particular entities are different. So it can definitely look different. I'm just, my point only is if indeed we're seeing that much separation here, I mean, I just find it hard to believe we wouldn't see some evidence of that on one of the other two studies.
Well, Roger, manometry doesn't lie. And if you were taking an inspiration, and if that was on the chest, it should have decreased pressure, not increased it.
You have more faith in manometry than I do, and I love manometry.
Okay, I'm going to move us forward a little bit. So I want to start talking. So before we kind of say what did we end up doing, I want to take a few more minutes to talk about the Chicago classification and the new changes in version 4. So what I'm showing you here is Chicago 3. And what you'll notice is that in Chicago 3, EGJ outflow obstruction is defined solely based on the IRP criteria of more than 15 millimeters of mercury on a supine swallow. And I think what we've all realized over the last several years is that the IRP is actually a very sensitive metric. And as with most metrics that are codified in guidelines, it's often viewed as an absolute. Below 15, normal. Above 15, abnormal. But instead, the IRP is more like a probability that something is abnormal, not necessarily a line in the sand. And so what I'm showing you here, this is a nice study from our group here at Stanford, including Drs. Kark and Dr. T, where they looked at 428 manometries that were done on patients who were having upper esophageal complaints that were that didn't have any evidence of mechanical obstruction by endoscopy or retroflexion. And what you can see here is that of those 428 studies, 116 ended up with a diagnosis of EGJ outflow, so 24%. And that's in line with other literature showing that using Chicago 3, about 10% of manometries all comers are found to have EGJ outflow, which is pretty high. The other thing you see here is that the majority of the studies with EGJ also showed peristaltic abnormalities, so spasm or hypercontractility or ineffective esophageal motility. What was also particularly interesting was that there were 17 patients in this cohort who actually had multiple manometries, and only 3 of them, 3 of the 17, had consistent, persistent EGJ outflow, which highlights either the transient fluid nature of EGJ outflow, or perhaps that the way we're defining EGJ outflow is subject to artifact or features that aren't clinically stable or relevant. So with that, I'll introduce Chicago 4. So one of the goals of Chicago 4 was to make the diagnosis of EGJ outflow more precise and more stringent and more clinically relevant. So with Chicago 4, a manometric diagnosis of EGJ outflow is defined as an elevated median IRP in the primary position, which most often is going to be supine, so an IRP of more than 15. But you also need the elevation in IRP in a secondary position, so usually in the upright position. There needs to be persistence of that elevation of the IRP. and you need intrabolus pressurization in at least 20% of those swallows. So with that, you'll get sort of the first part of the manometric diagnosis. But even with that manometric diagnosis, that's always inconclusive based on Chicago 4, and you need complementary testing. So either an esophagram and preferably a timed barium esophagram, or an endoflip confirming the obstruction. And even then, that finding may not be clinically relevant. So a clinically relevant conclusive diagnosis of EGJ outflow requires the manometric criteria, so the elevated supine IRP, elevated upright IRP, elevated intrabolus pressure in at least 20%, and an abnormal time barium esophagram or flip. And as Roger mentioned, you need to have a clinically relevant symptom, which is defined as dysphagia or non-cardiac chest pain. So to get to this new clinically relevant diagnosis of EGJ is much harder with Chicago 4, or I should say it's much more strict. And to take this one step further, what I'm showing here on this slide are causes of EGJ outflow, many of which don't reflect true outflow obstruction and which are not clinically relevant, which is why there's this new pressure to think of EGJ outflow as more of a finding than a disease in and of itself. And we've talked about a number of these already in our discussions, but sometimes EGJ outflow is the result of a technical issue with the manometry catheter. So when you're in a supine position, the manometry catheter can end up lying against or pressing on the side of the esophagus, which will lead to an artificial elevation in pressure. So when you put a patient upright and the catheter sort of comes back towards the middle, that artifact tends to improve, which is why in the new Chicago 4, and even before Chicago 4, many of us were saying, if you don't see elevated IRPs in both the supine and upright position, that may be artifact from the catheter. Another technical issue is misplaced gastric baseline. So for those of us who read manometry, we know that where you put the gastric baseline will absolutely change your IRP. So the IRP, that relaxation pressure, is calculated relative to a gastric pressure that you set. And so if you set the gastric pressure, let's say in an area of a lot of pressurization right underneath the crural diaphragm, you will get a much smaller difference and a much lower IRP. If you place it, let's say you have a place where it's much deeper or there's much lower pressure, you will get an enhanced difference in the IRP. So where you place the gastric baseline has a huge influence, which highlights that ultimately this is a calculated metric. It's not an absolute truth. The other thing that we discussed is that the IRP is very sensitive to things like rapid respiratory rate and diaphragmatic contraction. So that will inflate the IRP. If there's a vascular artifact at the GEJ, that will inflate the IRP. Other things like obesity will elevate the intragastric pressure. So there's a common cavity effect during LES relaxation where you can see an elevation in that space because of the common cavity effect in obesity. We also know that opiates can elevate the IRPs, as can the configuration of large but also small hiatal hernias. So the key of all this is to say that when a patient has an elevated IRP on manometry, you have to determine whether this is a clinically significant outflow obstruction that you definitely don't want to miss before taking them to the OR, for example, or whether this is something that's an artifact or clinically insignificant. And that's where things like esophograms and endoflips, and sometimes just repeating the study in 3 to 6 months can help answer these questions. In our case, the guy does end up having a small hernia. He is obese. There is prominence of the diaphragmatic contraction, and he doesn't have symptoms. So you might say, this is probably not clinically relevant. On the other hand, he does have outflow obstruction persistent in the supine and upright periods, and there's intrabolus pressurization, and he had that outside upper GI that was concerning. So I'll take us back to the case. I'll say that after I did his endoscopy and I read his manometry, I saw him for the first time in clinic. I really went through very detailed any possible symptoms that he might have of anything, but he had no dysphagia, no globus, no heartburn, no regurgitation, no cough, no chest pain. I mean, I can't say I've ever had a patient who had none of those, but he had nothing. But because of this being a preoperative scenario and us really not wanting to miss true obstruction and there being enough signals, I decided to go ahead and order a dedicated esophagram. And this is pre-Chicago 4, so maybe looking back, it should have been a time variant, but I ordered a regular esophagram and then a repeat endoscopy with EndoFlip. I'm not going to show the images from the esophagram, but I'll say that the esophagram showed normal morphology. There was some decrease in primary peristalsis, but the contrast passed easily into the stomach, and I asked for it to be done with a 13mm tablet, which passed easily into the stomach as well. There was a small hernia, and that's kind of what we saw on the esophagram. So I want to spend a little bit more time, though, talking about the EndoFlip, and I'm actually going to turn this back to John to take us through a little bit of the basics of EndoFlip before we talk about his actual results.
Sounds good. Thanks, Patty. So I'll talk just a bit about background here. And so when doing EndoFlip, this is a balloon which looks at impedance planimetry to calculate diameter between each ring pair, as well as cross-sectional area of that section of the balloon. It has one pressure sensor inside, which then lets you calculate distensibility. And what you see when doing it, next slide, please, is that it looks like a system like this. And so on your right side, you're seeing the cart with the Flip 1.0 that's on the bottom, which is just a 2D image. And then on the upper screen, you have topography, which looks at contractions. On the left-hand side, you're seeing what this balloon looks like. And so in most cases, you're passing this down transorally without the endoscopy, placing it based on the topographic profile, and then inflating. But you can insert this through the accessory channel of one large endoscope from two of the three main companies, which does allow you to then direct it within certain areas. And so if you have a stricture, if you're looking at the pylorus, that can be helpful in getting measurements in that area. Next slide, please. In terms of the protocol, there was a recent paper within the Red journal that came out last year that polled experts in terms of the way that they'd recommend doing it. Prior to that, everyone was doing their own protocol on each site. But right now, the way that's recommended from that is, if you're doing the longer balloon, the 16-centimeter one, to place it within the area of interest, inflate it to about 30 just to get location and make sure you're in the right spot. And then at that point, start measuring every 10 cc's going up from 30 towards 70, staying in place for between half a minute to a minute at 40, 50, 60, and sometimes 70. Next slide, please. And what you're essentially looking for in this study is three things. You're looking for what diameter is, and you want to see in normal health that you have a junction that goes up to at least 18 or higher. You're also looking at distensibility. And if that's greater than 3, that's considered at this point normal. If it's between 2 and 3, it's borderline. If it's less than 2, it's tight. Now, it's important to keep in mind when doing this that there is just one pressure sensor. So if your pressure sensor is out for whatever reason, then you may have a situation that you have that you have a diameter that looks normal, but distensibility is off. So just keep it in mind when you're doing that. And then you're also looking with the Flip 2.0 as well at contractility. And this for me has been one of those things that I can say I've never quite followed the mechanisms of this. It seems to me that when we look at a manometry and we see a whole bunch of different discordant patterns, and we're trying to separate, what's hypercontractile and what's an IEM pattern, it seems strange that we can then go to Flip and everything is either forwards or backwards. But right now it does look like the Flip secondary peristaltic profile that we see is at this point somewhat narrow. And so what you're essentially looking for is to see if you have recurrent forward contractions, which would be normal, if you have retrograde contractions, which are more indicative of spasm or achalasia, or if you have absent or else something in the middle of these. Next slide, please.
I think that's your last slide.
Okay.
So maybe I'll take the ball back.
Sounds good.
So what you can see here is this patient's endoflip. And so on the right, you're seeing the images that John was sort of describing. What you get is this topography, which is really looking at secondary peristalsis, because you have a balloon that, the patient's asleep and under anesthesia, so you have a balloon that's causing pressure, and then you get these secondary peristaltic waves. Now, I'll just go back a slide to tell you that this pattern here is what normal looks like. So you have these repetitive antegrade contractions. What you can see here is that there aren't any contractions, and that's not normal. But probably more than topography, what we really think about when we're looking at the endoflip is, again, this distensibility at the EGJ. And so you get this sort of nice hourglass figure that kind of, I think, is very intuitive for our eyes to say, does this look tight? Do I still see that there's an hourglass? I'll say from a numbers perspective, again, what you see here is that this column, which is the distensibility index, again, anything less than 3, we think of as being lower in distensibility. A diameter, we think anything less than 18. So what you can see here is that there is evidence of decreased compliance. There is absent contractility. Maybe one thing I'll say, which is a little bit kind of into the weeds, but I think is important to think about with endoflip, is the pressures. So I think oftentimes people really focus on the distensibility and the diameter, but you have to remember that the pressure, this is a pressure that we are inducing artificially. And so this pressure here, for example, of 50, that's much higher than the esophagus would ever generate on its own. And I think that makes it even more pronounced, this finding even more pronounced, that even at a very high pressure, the diameter is still quite low. I'll say that we often see kind of something that is the reverse, where there will be a very high pressure, maybe 60, and the diameter will be 18. I think you always have to think to yourself when you're doing endoflips, well, at a pressure of 60, yeah, the esophagus is 18, but that's a very artificial, non-physiologic setting. So I think it's important to kind of look at all of these numbers in relationship to themselves. But at the end of the day, what this endoflip shows is that there does seem to be a bit of outflow obstruction. So definitely not normal. And so I'll turn this back again to the group for discussion. So now what? We have this endoflip that shows that there is some evidence of outflow obstruction. We have the manometry, which shows outflow obstruction, but we have a repeat esophagram with a tablet that was normal. We have a patient who is completely asymptomatic. So what now?
I mean, we've chased this about as far as it can go at this point. I think we started with a test that was just a pre-op test. We found something abnormal. We did, 3 other follow-up studies, which have all essentially confirmed that. And it looks like what we have is decreased distensibility in the context of a small hernia with no symptoms whatsoever. And so I think it comes down to the question of there's no additional testing that I can see to look at the obstructive component, unless we wanted to chase this with like an EUS going past that. But we've essentially reached the end of the road, and we're at the question of, is this clinically relevant, and does this change the choice of operation? So I think it goes back towards Dan and colleagues.
I agree.
I agree with that, John. And I think you can't lose sight of the bigger picture. You've got a patient there. You're not just doing tests and looking at results. You've got somebody who needs urgent sort of bariatric surgery to get their transplant. So if I was committed to the sleeve, I'd be thinking about, obviously fixing that hiatus hernia at the time of the sleeve. But, there still are other options available. So I'd also be discussing it with my colleagues and maybe a multidisciplinary team meeting.
Yeah, I would agree with that. I think we surgeons are pretty practical, so we don't tend to hair split on the diagnostic naming the disease, but we have a pretty simple rule that if there's an abnormal esophagus, we won't do a sleeve. Sleeves are bad for the esophagus, so you have to have a pretty robust, and as Matt says, there's other alternatives, and for this patient, we'd probably do an endo sleeve, endoscopic sleeve gastroplasty.
Go ahead, Walter.
Oh, I was going to say, I mean, I think I agree with everyone that like I wouldn't do any more either treatment or testing, because I think we kind of established that there's some sort of obstructive physiology. I think the question was like, I think everyone's leaning towards a sleeve of some sort. I think Lee mentioned doing an endo sleeve to kind of, because of the abnormality potentially. But it seems like having an obstructive physiology at the LES, having a sleeve physiologically would probably not be the best idea. I know there are not that many options out there, especially given the contraindication with RON-Y. It's likely that, with increasing intragastric pressure with a sleeve plus, an EGJ outflow obstruction, that it might more likely induce more obstructive physiology and maybe induce more symptoms post-operatively. So, I guess that's the dilemma here in terms of like, in this situation, I think maybe something like RON-Y would be better physiologically, but there's the caveat of the transplant.
Yeah, I will say that endoscopic gastroplasties are a low pressure system, so they're not high pressure like a laparoscopic sleeve is. So I mean that's the reason we would go that direction. They're not as effective, but they're pretty benign for the esophagus.
How about Botox or dilation of the G junction? Would that be diagnostically and therapeutically useful or contraindicated, or how do you see that from the surgical perspective, Dan, Lee, and Roger?
I'll say two things. The problem is it's also difficult to assess, how would you assess success in somebody who's asymptomatic? So you'd have to retest him. and so the other thing is I promise we did not make this up just for this discussion. I mean this is an ideal discussion scenario, but as you all said, I think the problem is we have an asymptomatic patient there that was just like coming in hoping to get help losing weight to get on the transplant list. And so I think there are that's the kind of the crux of it. I would totally agree that if the kidney was not an issue, and I went back to the transplant folks and say, like how strongly do you feel about not doing a bypass on this patient? And they feel pretty strongly about it. And I must say, I agree. If you're doing this to bridge him to transplant, and he loses his transplant, the first year, then you really have not helped them at all. So I don't know if Erwin or Denis have other thoughts, but at this point, I don't think kind of treating his outflow obstruction in a way would help us.
And the other thing I would add to that is that you have to consider that a patient who has no dysphagia or obstructive symptoms, even with these, physiologic findings, anything to address that would be potentially refluxogenic, actually, which would be counterproductive as well in this situation.
What a perfect segue.
Yeah, maybe I'll just take that segue and then we can talk a bit more. To say what did we end up doing is we had a discussion like we're having now. So at Stanford, we have our own expert panel discussions every Thursday. We have a foregut conference where essentially us in motility GI and our foregut surgeons like Dan and others and our radiologists come together to do essentially what we're doing here and review the studies, review the case, look at the images, more than we're doing here, actually look at live radiology images, actually run through the manometry studies. And we try to make decisions. So at this foregut conference that we had in December, we decided, I think what the group here is saying, which is that we've kind of really beat this dead horse. And despite the kind of conflicting evidence and the fact that probably there is a bit of outflow obstruction, there's no symptoms, and it's not really going to make that big of a difference in terms of surgical planning, and that we would leave that alone. I'll say that also with the new Chicago, looking back, this case wouldn't technically classify as that clinically relevant conclusive diagnosis because the patient is asymptomatic. So that said, when we had this multidisciplinary discussion, one of the things that was brought up was something that Roger was just talking about too, which is reflux, and how this conversation about doing a procedure in a patient who cannot get a Roux-en-Y as a backup. So sometimes when patients get a sleeve, if they get terrible reflux, you can think of Roux-en-Y as a backup. Now, I'm not a surgeon, so I know that it's complex, but at least that's an option that's out there. In this case, that wouldn't be an option. And so there was a lot of discussion about whether we should test him for reflux, even though he's asymptomatic. And I'll kind of spare the discussion there and just show you that we did do it. So we decided to do a Bravo off therapy on this patient. And what you can see here is that the overall percent acid exposure is 6.5 and the demister is 21.2. Just for those of us who don't read these all the time, a demister of 14.7 or higher is thought to be abnormal, and greater than 6% exposure is thought to be abnormal. Now, we did a 4-day test, and so I think it's important not to look at the composite because that'll just blur all the differences, but to look at the day by day. What you can see here is that days 1 and 2 were clearly abnormal, with demisters from 20 to 30 and percent acid exposures from 6 to 11. Day 3 was normal and day 4 was borderline. But overall, if you kind of are taking this as a reflection of what's likely occurring in this patient, he probably does have some clinically relevant acid reflux despite being asymptomatic. And perhaps that is related to his obesity, but needless to say, there's acid reflux here. So now what? And I'll turn this back to the group.
I mean, I'd probably throw out that, you know, if his weight is what prevents him from getting the kidney transplant, and he needs that for his long-term quality of life, and you know, Roux is outside the picture and he has no symptoms whatsoever, I would probably lean towards doing a sleeve of some sort, but just going ahead and biting the bullet. You know, I don't think medical weight loss will be that successful in the grand scheme, and I think it may be challenging to do also with his kidney issues, and I think his harm from not getting the transplant, you know, is probably significant enough that I'd probably just go, you know, just bite the bullet and do it. But of course, that's easy for me to say because I'm not the one doing it.
Yeah.
If he has rip-roaring reflux afterwards, they're gonna. I'll send him back to you and Patty. So.
Yeah, exactly.
Is there really that urgency to do the surgery and the transplant? Like, I don't deny that, you know, if he ends up on dialysis, that's an issue of quality of life. Obviously, he has a high BMI, which can have other consequences, but he's presumably had this high BMI for a long time. And I don't know if he was going to have bariatric surgery if this issue of the kidney transplant didn't come up. So I think all of this discussion is very relevant, but there isn't an urgency. It's not it's something that must be done immediately. So the option of maybe sitting on this for a little bit and seeing how he does is also there, because going back to the obstruction that we were looking at, we've all seen patients with achalasia who says, you know, their symptoms started 6 months ago, and yet the esophagus is so involved, there's no way that this started 6 months ago. So there is certainly a period that they can be asymptomatic. Now, again, this person does not have achalasia right now, but you never know what might happen in the next year, for example. So just throwing that out there, because this is not something that absolutely must be done this very second in time.
So you propose a repeat examination in 6 months to a year and just wait it out, huh?
You can consider that, sure. And you might see how he does as far as symptoms, because sometimes they come back and they maybe will have some upper GI symptoms at that point, which can influence things. So.
This is Erwin, hi from Austria. I just wondered, do you guys have any kind of cutoff where you need to go prior to transplant surgery? I mean, 44 BMI is pretty high, but we usually do guys with 35. So do you have a cutoff where he has to go? So otherwise
They won't list him unless he's below 35.
Okay. So what we've seen actually the last years that the sleeve itself is very refluxogenic. So we've learned that 10 years after the sleeve, 50% have a Barrett's esophagus, nearly 10% after 10 years have non-treatable reflux disease. So we're not very happy with sleeve gastrectomy anymore. So we're more on this mini gastric bypass, the omega loop gastric bypass, but this may be country-based.
Apropos to this, one of the people on chat says, how about links and maybe in conjunction with sleeve?
Yeah. So we can, I think that's my next,
yeah, sure. Let
that's
me,
my next slide. So we can,
yes. Well, I'll say,
jump to that.
I think one quick discussion. So we did discuss this again in our multidisciplinary conference, and we decided to optimize medical weight loss options, but I will turn this back to Dan for that.
Yeah. And so what I'll say is, you know, I'll put my my kind of weight loss hat on, and I think what we've been doing here is changing a little bit our paradigm in terms of weight loss management, and trying to really build a clinic that is multidisciplinary, and where it's not only like a surgical clinic and we do a little bit of medical weight loss. So we just hired a new medical weight loss specialist. We have a series of programs now for medical weight loss. And the other thing, I you know, I don't want to get on my soapbox for too long, but I think there are now there are more and more good medical treatments for weight loss. And I think GLP-1 agonists and the results from the newest GLP-1 agonist, which is semaglutide, have just come out. And for those of you who do weight loss, you'll see that it's starting to be a game changer, right? When you look at total body weight loss for a sleeve, we're talking somewhere around 20%. Semaglutide results were somewhere around 15, 16%. And so you're starting to have a medical treatment that is at least in the same ballpark as some of our surgical procedures, definitely in the same ballpark as some of the endoscopic procedures that we were discussing before. And so I think, you know, as surgeons, I remember pretty vividly a discussion about reflux with one of the figures of anti-reflux surgery, 20 years ago, where I think the question is how, the non-biased option of a surgeon is that you can treat somebody, including with PPI, for anti-reflux, and I see it the same way for weight loss. I think discarding medical weight loss is something that we've done too much, and so let's see how he does on a medical weight loss program. We'll see if we can get him on, there's still a lot of barriers on getting these patients on GLP-1 agonists, including cost and things like that. But, semaglutide is a 1 weekly injection. And so, I think there are really a lot of ways that we can help patients now successfully with non-surgical weight loss. So we'll put him in that program. And I think from my perspective, the feeling is it's at least worth a good, decent shot with, a 6 to 12 months program. See if we can get him under that barrier of 35, and then hopefully get him to his goal and get him to a transplant. And if he fails, we could discuss this, which is doing a sleeve. And I don't want to go too theoretical, but I think many of you are familiar with the issues with the sleeve, and Erwin just pointed to that. This is something still that is very poorly understood. The consequences are slowly bubbling up. Those of us who do them see how at least we all have case series of patients who develop rip-roaring reflux within weeks to months of a sleeve, with some of them that have horrible acid exposure and had at least no symptoms before, and some of them had a normal Bravo before. It is the main cause of impaired quality of life after sleeve. It is the one thing that will make patients miserable after a sleeve. And I think for those patients, what we what we recommend if they come up with acid reflux after a sleeve is obviously to repeat the workup that we discussed with a pH and a manometry. One technical aspect that we look for is a stricture. I think oftentimes some of these patients you will see on an upper GI a mid-body stricture that makes an even higher pressure system inside the stomach. You want to go to the next slide. And to touch on some of the I think that might be the old. Go to the next slide quickly. Yeah, no, that's fine. So sorry, one back slide. So to the point that that was raised on the chat is how do we treat them after after a sleeve for reflux? And these are the options. And Ram pointed to links. There's been data on Stretta as well. And there's obviously PPIs and endoscopy. My personal algorithm, and you can go to the next slide, looks a little bit more like this. And if they don't respond to medical therapy, I go pretty quickly to convert them to a Roux-en-Y. And the reason for that is I think if there is any sort of stricture, there is data on dilating the stricture. I think it's very hard to get these strictures to stay open. And oftentimes what ends up happening is you kind of drag these patients along for weeks and months of non-surgical therapy. They're miserable, and they really hate you by the time you decide to convert them to a Roux-en-Y gastric bypass. And so I've been a little bit more aggressive at if they don't respond to medical therapy, I think the right way to go is to treat their acid reflux aggressively with a conversion to a Roux-en-Y gastric bypass. I think the Stretta has had some promise, but the data has been disappointing in terms of post-sleeve. And I think we can all imagine why, and if you're looking at the pathophysiology and the physiology of this. And honestly, and I'll this is my last slide, so we can bring up the discussion now. But to me, the links, if you're going to tackle this surgically, I think a gastric bypass is a better overall option in terms of treating not only their acid reflux, but most times these patients don't have a BMI that's back to normal, and therefore, let's say their BMI went from 55 to 40. I think offering them a gastric bypass will also come into the equation in helping them lose the rest of the weight that they need to lose. So I'll open up for the conversation that I think we had started about how do you manage acid reflux? Where does the sleeve come in? And any thoughts about this?
Just a quick question, Dan. That's Matt.
Yeah.
The stricturing you're referring to, is that more the technical issue of narrowing at the incisura?
Yeah, and yeah, I think that's something that I don't think it's the primary cause of patients having GERD after sleeve. I think the majority of patients who have even severe acid reflux have a normal sleeve anatomy, and it's not a technical issue. But I think we've all seen some patients with a combo of acid reflux and often dysphagia who have a mid-body stricture at the incisura that is, at least if not the underlying cause, one of the underlying mechanisms for their symptoms.
Dan, I don't know what's still what's FDA approved right now at the moment, but could this be a situation with doing like a gastric balloon to temporarily lose weight and then take it out and transplant, or is that not something that's an option anymore?
So, I have my own opinions about the gastric balloon in general. I think, I'm not sure it's the best treatment for obesity. I can, I think it's a temporary solution to a chronic problem. And I think most people who, I think balloons have a place somewhere in the equation. But I think most people would feel pretty uncomfortable putting a balloon in a post-sleeve situation. I think the room for or the option for a pretty bad disaster is worse. So, oh, but sorry, you were saying putting.
Did you mean pre-sleeve, John?
Like what about now with an
yeah.
Sorry, I got completely.
Yeah.
I thought you were talking about, weight loss after sleep. Sorry, I got.
No, I was thinking maybe doing it now, getting the weight down, training planning, just to get under the BMI threshold.
I think the hiatus hernia might be a relative contraindication.
So you can do it with a small hiatal hernia. I think so. So to the point of what that was going to, like, it has place in the equation. I think these bridges situation where you have either very high BMI patients or patients who need something to bridge them to something else. I think the balloon is a potentially good option. The FDA situation is the biggest hurdle at this point is that it never got reimbursed anyway. And so this is, in the US, this is all out of pocket. And so it's not an option for most patients just because they would have to pay for it out of pocket. Otherwise, it could be an option. Now, again, my preference at this point in time, what we see with like semaglutide is better weight loss than what you would see with the balloon. So.
The other comment I'd like to make, Dan, is it needs to be multimodal. It can't just be surgery or medication alone. So we always refer our patients to a psychologist, dietitian, and even sometimes an exercise physiologist. So we combine all those services.
For weight loss, you mean?
Correct.
Yeah. So that's what we've been building here. Is we have psychologists, we have dietitians in the clinic, we have our weight loss specialists, and we're working with physical therapy and physical coaches as well to really build kind of a real weight loss program. And I think that's I totally agree. It's important as an alternative to surgery. It's important as a perioperative, and it's important as postoperative in the percent of patients who will regain some weight. But I think, Hiroshi, you were going to say something.
Oh, thanks. Yeah, not to hog bandwidth, but so not to make a shameless plug, but I did do a review article with FAS on the effects of both surgical and endoscopic bariatric treatments with implication to GERD, which is in our Society Journal of Neurogastroenterology and Motility in January. But that said, I do want to pose two other issues other than the medicine. There is, of course, both Boston-based, hooray, on fractal and endo barriers, which of course is being used more in Europe now. Endo barriers is a duodenal bypass with a sleeve. It shouldn't be called a sleeve, it's a bypass liner. But it does make physiological sense in the sense that you're avoiding the same area in terms of the proximal duodenum. So it has a lot of the metabolic syndrome reversal issues. Fractal, I can't understand or justify, but certainly is being studied also in Europe, although they're both Boston-based companies, which is to reface the duodenum by burning it or using hot water, I guess. So, but I have to say for the audience that the endo barrier is somewhat on hold here in the United States, because when you put that barrier, there have been instances of hepatic abscesses, which just goes to show that you alter the microbiome there. And fractal, I'm not sure of what studies are being done in the States, but I'm just throwing it out there. This is Roshi.
Yeah, this is Lee. We're involved in both those European studies. You do have to note that both of those are listed as metabolic procedures, and that's because their initial studies didn't show a lot of weight loss. And since that's the main goal of this patient, to get them below that BMI level, those might not be the best treatments. But I agree, you should look into endoscopic things because they're very, very minimally invasive, well tolerated, and relatively effective. Maybe not over the long term, but for a few years.
Oh, Lee, my impression was that at least the endo barrier was also weight losing, not just in reversal of NAFLD. But Lee, you would know, and I do like that because, as you were mentioning, some of these kind of endo barrier like things decreases gastric pressure, unlike, let's say, the balloon that Dan was just mentioning that he's also not too enthusiastic about.
Yeah, you do lose some weight. I'm just not sure you could bring a BMI of 44 down to that level 35 that the transplant guys want.
No, and Hiroshi, I agree. There are many options out there, and I think that's, you know, again, not to keep plugging on this, but I think that's why it's important to have a clinic, a weight loss clinic, where you have all the options. And you know, Dr. Escovel is a new surgeon with us. She's been training with John and Juha and doing advanced endoscopy to offer some of the things that, you know, like Lee does. And I think it's important to say, okay, here are all the options, and we can try multiple things, and we can put you on semaglutide and, you know, add an endoscopic procedure to this. And I think that's the way that things are going to go in the future. Or I think that's the way we're doing things already now, in terms of quickly adding medications to patients even post-surgery or things like that. So I completely agree that this is multimodal therapy. There are many, you know, the innovations in terms of weight loss. There's also, unfortunately, a huge, you know, graveyard of technologies that have failed, and I think it's very hard to develop a good weight loss technology. There's another Boston-based company that does a gel that fills your stomach. There's a Biodesign kind of spinoff that is also, I think now, he was at Hopkins, but I think he's now based out of Boston with a gastroenterologist you guys might know, Ashish, who's developing a similar and sort of endoscopic, not endoscopic, medical coating. It's called Glixend. So there are many things down in the pipeline. And I think the weight management sphere is going to keep evolving. But I think for this gentleman, you know, the options are a little bit limited.
So it seems that this fellow cannot qualify for Roux-en-Y bypass, correct? Because of his kidney prospects?
Yeah. Again, I kind of brought it, and there's some, oh, go ahead, Matt.
I was just going to say, you mentioned the issue of graft failure, but there's also probably the more real issue of, you know, marginal ulceration, you know, post bypass on immunosuppression. You know, that's probably the more sort of, from a surgical point of view, that's something that's really difficult to manage.
Yeah, no, I think clearly in these patients, and Erwin might defer, but I think sleeve is a good option. And you know, I think the pendulum is going to swing on the sleeve. I think that's also to plug in for training. I think that's why it's also important to make sure that our trainees still know how to do gastric bypasses, because we're going to do a lot of sleeve to gastric bypasses in the future. And I can already see my practice has shifted quite a bit. But to your point, Matt, I think there are more complications overall, reoperations in patients who are going to be immunosuppressed after a gastric bypass compared to a sleeve. I think there's probably going to need more kind of consensus on how we monitor patients with sleeves in terms of potential acid reflux damage. And there's been talk about, you know, we should probably start recommending these patients to get screening endoscopies after a few years. And I don't want to open a big Pandora's box, but I think that is something that is recommendable for most patients who've had a sleeve. But I did go back to the kidney transplant folks, as I said, and they were pretty adamant that they also feel pretty uncomfortable with a Roux-en-Y gastric bypass pre and post kidney transplant. There is some data out there of patients of people who did Roux-en-Ys pre-post kidney transplant, and the data is not horrible. But I think, again, I think the potential to undermine what we're trying to do, which is get this gentleman to a healthy weight and off dialysis, if he loses his graft, I think we've lost. We didn't help him overall in the long run.
I would like to pick on the point that you mentioned about screening after sleeve, and I think that's a very important one because that identifies Barrett's esophagus, and that is a predisposing condition to esophageal cancer. So I think that probably should enter into the equation and be practiced by most surgeons. And there are some studies that have actually raised that possibility, and I think on the surgical side, it should be a significant consideration.
I agree, and I think we've seen again, more than anecdotally, we've seen patients develop esophagitis in a time frame that is interestingly quick and somewhat scaringly quick after sleeve. And so I think there is something that we again still don't understand. And you know, Patty, John, and I have been talking about you know, the need to investigate this further and do more research around this to really understand what's going on and why these patients develop these rapidly evolving esophageal consequences after a sleeve.
And it's also important to diagnose it preoperatively. You know, I like the point, Dan, that you do routine endoscopy because not everyone around the world does that.
Yeah, and that's also a point of debate where, you know, some patients we get denied from insurance. We, you know, I think Roger brought this up. We like to do the endoscopies and ourselves, and so we typically we will scope our own patients before all of our bariatric patients, unless, you know, they need expert workup and manometry and other things in addition to that, and that's when Patty and John will come in and scope them.
I was going to say, you know, at University of Washington, we have a relatively low threshold for using manometry and pH studies anyway. So I do know that my bariatric colleagues there do manometry and pH on anyone that they're contemplating doing a sleeve for up front, just to, you know, to see if they have silent reflux. And I think that's relatively helpful.
Yeah, absolutely. And that's actually one of the conversations that we're having with Patty and John is to see if clinically this is something that we need to do. And I don't know if Erwin's still on. Yeah, here he is. But I do think that I don't think the sleeve is going to go away, but I do think that we probably need better pre-op evaluations and in order to guide these patients to a sleeve or to a bypass.
I talked to one of our bariatric colleagues before. We used to have endoscopy in a way. We used to have manometry and pH metry in any patient who got a bariatric procedure. But now there's time frame wise, we can't do that anymore. It's kind of a pity, but we would like to have that because there's no insurance issue. So we used to have that.
Yeah, we time wise, we unfortunately the insurance companies here put a lot of barriers before they can get bariatric surgery, and usually that involves like a 6 months process of trying to lose weight. And so we unfortunately, in a sense, have a lot of time to do a lot of pre-op workup in these patients because their surgery is usually delayed for insurance purposes. And let's see a question in the chat. Ron, what is the choice if a patient has known reflux and diabetes and is keen to get onto the transplant list and has tried all the medical management? Can we offer a sleeve with the knowledge that the patient will have to be on long-term PPI? So I think that's the challenge. The challenge is it's not only that he will be on long-term PPI, is if he doesn't respond to PPI. I think most of us would be pretty comfortable if, you know, if we do a sleeve on this gentleman and he does develop acid reflux and he responds to PPI, then that's the best possible outcome we could hope for in this setting. The problem is if he does not respond to that, and we go from, you know, a non-transplant candidate to a transplant candidate, to a non-transplant candidate who's asymptomatic to a transplant candidate now who's miserable with debilitating acid reflux, right, and not responding to PPI. And I think that's the challenge if we can't then convert him to a gastric bypass. So, maybe to get to the conclusion of this, my thought process for this gentleman would be to pursue aggressive medical weight loss. I think if he does not respond to medical weight loss and this is his only option, I would potentially consider a sleeve with, an aggressive kind of hiatal hernia repair at the same time, and hope that he does okay in that setting, with the understanding with that if he is, and if he doesn't and he does well in PPI, great. And worst case scenario, if he does develop debilitating reflux, that we would consider potentially a Roux-en-Y gastric bypass with very careful monitoring of his oxalate levels and things like that. So I think there is kind of, at that point, we have enough barriers to protect him. But that would be the thought process and the current conclusion for this gentleman, hoping that he responds to the first line therapy with the GLP-1 agonist and some other meds.
I'd just like to say a quick thank you as well towards Patty. Patty put this case and slides together and really did a great job with it. This is her first talk with the OESO group and hopefully the first of many. She has to run towards something which she's presenting elsewhere now, but I just wanted to thank her from the group and just tell her a great job. So thank you, Patty.
Thank you, guys. This is super wonderful. I love these multidisciplinary discussions. I love having them at Stanford, and it's much cooler to have it internationally. So thank you guys so much for allowing me to participate.
Thanks, Patty, and Matt, thanks for staying up so late.
That's right. Good night, everyone. Good morning.
Good morning.
Sounds good. I think
John?
Yes, I would like just to say that it was really a fascinating discussion with all the nuances of a therapeutic strategy of the highest complexity. And it was an impressive synthesis. Thank you to all. Thank you to George, to John, to Patricia, to Roger Tatum, that I was glad to see again on screen today. And of course, Hiroshi Mashimo, and also people in the virtual floor that have contributed to the interest of the discussion. In one word, I would like to say that this is the original educational approach proposed by the pilot centers of the OESO-SEMPIRE platform of esophagology. And it is from such a synthesis that a virtual recapitulation could be possibly organized at the end of the year, drawn from the strongest elements of the debates of the preceding month. And this is something we should think about and that we will probably discuss next week at the time of the board meeting of the organization. And as of now, I would like you to mark our next meeting on your calendars. It will be on April the 15th, and it will be from the Pilot Center in Paris. I can promise you already a very challenging moment. And thank you to all for having organized such an interesting and fantastic discussion today. Thank you.